This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending neurosurgeon.
And I'm Dr. Laura, a research fellow. Today we're looking at a fascinating new study from World Neurosurgery, published in 2026. The title is A Fixed Left-Sided Surgeon Position in Unilateral Biportal Endoscopic Surgery for Lumbar Disc Herniation, a technical note with variations according to herniation type.
This is a timely topic, Laura. Unilateral biportal endoscopy, or UBE, has been gaining significant traction in our field lately. For those listening who are just getting into the endoscopic space, UBE is a bimanual technique, unlike the uniportal approach, which gives us a lot more freedom of movement with our instruments. But as we know, the ergonomics of these cases can be tricky.
Exactly. In many standard UBE protocols for lumbar disc herniation, or LDH, the common practice is to adapt the surgeon's position based on the laterality of the herniation. If it's a right-sided herniation, the surgeon often stands on the right. If it's left, they stand on the left.
And that's exactly where the friction starts in the OR. If you're switching sides every other case, you're constantly rearranging the monitors, the irrigation towers, and the fluoroscopy setup. It's not just a matter of the surgeon walking to the other side. It affects the entire operating room workflow.
That is the primary problem this technical note addresses. The authors point out that adapting the surgeon's position according to herniation laterality may negatively affect not only the workflow, but also the ergonomics for the surgeon. They wanted to document the feasibility and clinical impact of a fixed surgeon positioning strategy, specifically staying on the left side of the patient, regardless of whether the herniation is on the left or the right.
Staying on the left for everything. That sounds efficient from a nursing and staff perspective, but for the surgeon, it changes the geometry of the approach, especially for contralateral or even certain types of ipsilateral herniations. What did the paper highlight regarding the technical execution?
The paper emphasizes that this is a fixed left-sided surgeon position. To make this work, the authors describe specific technical variations according to herniation type. Because the surgeon isn't moving, the angles of the portals, the viewing portal and the working portal, must be adjusted to reach the pathology effectively.
Right. In a bimanual technique like UBE, your triangulation is everything. If you are standing on the left and treating a right-sided herniation, you're essentially performing a contralateral approach. The abstract mentions that the clinical impact and feasibility of this fixed strategy hasn't been sufficiently documented until now. By keeping the surgeon on the left, they are looking to standardize the environment.
Precisely. For our residents listening, think about the ergonomics. If you can master the hand-eye coordination from one fixed side, you're reducing the variables you have to manage. The paper suggests that this consistency in positioning could potentially lead to a more streamlined procedure. They really focus on the fact that this strategy is independent of herniation laterality.
It's an interesting shift in philosophy. We often think we need to be as close to the pathology as possible to maintain a natural line of sight. But with modern high-definition endoscopes and the biportal freedom, we can rethink that. Did the paper mention any specific challenges with the left-sided position for right-sided herniations?
The abstract highlights that the variations according to herniation type are the key. It implies that while the surgeon's feet stay in the same place, the way we handle the bimanual tools changes to accommodate the different types of LDH. The goal is to prove that you don't lose clinical efficacy by choosing workflow efficiency.
And that's the bottom line for practicing neurosurgeons. If we can show that clinical outcomes are stable while making the OR setup faster and the surgeon more comfortable, it's a win-win. This technical note serves as a roadmap for that standardization.
It definitely challenges the traditional side-switching model. For medical students and residents, it's a great reminder that even in advanced spine surgery, sometimes the most impactful innovations aren't a new tool, but a better way to position yourself at the table.
Very true. Well, that's a concise look at a very practical technical note. If you're performing UBE, it might be worth discussing a fixed-size strategy with your script team.
Thanks for joining us today on the Neurosurgery Hub podcast. We'll see you in the next episode.
Stay sharp.